okay, what we agree after the talk of Mancebo is that we are dancing with the good and the ugly, right? So maybe it's the most difficult part of the mechanics of ventilation is the work of breathing, maybe the more complicated. So I would like to make these disclosures. I received financials for many companies, but not for biases, and you will see why I'm telling this. Okay, the work of breathing. Jordi said before that is the energy spent for spontaneous ventilation, and in a fluid system is force by length, and in the applied to the respiratory system is pressure times volume. So it means that had been said already that is pressure times volume is expressed in 10 centimeters of water per liter, which is 1 joule. So, but this is mechanical work. So you have to move the air, you move the volume. So if you don't move volume, there is not mechanical work. Another thing is what we call metabolic works. That is the oxygen consumption due to the respiratory muscles, right? And the other thing, and maybe more important for in clinical practice, but is another thing, is that the effort. The effort is not the work. You can do effort without moving any air. So this is effort and it consumes energy, but there is not, mechanical work. So what's the interest of the work of breathing measurement? Just looking at this paper, looking for the outcomes when you monitor something, you can see that there are few, not many, but some of them respiratory monitoring. And looking at this, looking at the outcome, just 7. No one related to work of breathing. Don't worry. Work of breathing, nobody have performed yet, an outcome study. But in this paper, there is two things that I would like to comment related to work of breathing. So, if you use a therapy based only on bedside clinical observation, and if you evaluate the work of breathing only with clinical observation, evaluating it is often subjective, sometimes inadequate, and potentially harmful. So this is one thing. And the second thing, if you look at the work of breathing, maybe this is a physiological variable that can guide a therapeutic intervention, so, and even improve the outcome. So theoretically, work of breathing is interesting. But let's see what other authors said about work of breathing. This one, for example, the work of breathing yields important information to monitor the evolution of the patients and titrate the ventilatory support. Who here is titrating the ventilatory support looking at the work of breathing? I guess that nobody. Okay. Anyway, but going back to the 80s and 90s, work of breathing have been considered to be the best predictive factor in winning. The best predictive factor, even Jordi Mancebo and Belén Cabello said in the last, in a quite recent paper, saying that knowing the determinant of the work, the determinant, not only the work, but also the determinants of the work of breathing is essential for the effective use of mechanical ventilation, and also to assess readiness for winning. It's okay, but if you go in and you see the guidelines for winning, in the guidelines to assess the winning, the patient ready for winning, the criteria is improvement of cause of respiratory failure, adequate oxygenation, pH, hemodynamic stability, fever, hemoglobin, Glasgow, awareness, adequate coughing, and also pressure support less than 20. There is no clue on work of breathing being the best predictor, but there are some physiological predictors that are, to see if the pulmonary function is adequate, and you can realize of these parameters can be obtained from the patient very fast. You know, in 5 minutes you can see what's the respiratory frequency, etc., etc., etc. The point is even the FBT ratio, which is the rapid shallow breathing index. So the point is that all these winning predictors can have a good sensitivity, but they don't have a good specificity. So you can pass the test, or you cannot pass the test, and you can win, you know, already. The point is that these predictors depends on how and when are measured. So, for example, a lower rapid shallow breathing is measured on pressure support on CPAP versus TPs. So it's not the same rapid shallow breathing index. And there are many other factors unrelated to respiratory muscle activity or capacity, such as sex, age, endotracheal tube size, body position, etc. So, and the guidelines published in 2001 and 2007, both guidelines do not recommend the use of winning, you know, predictors for winning decision making. So you have not to, and it's based in the history and based in the clinical practice. Looking at just at this paper, there are two arms of patients. You know, one group following for winning, following standard criteria, measuring a rapid shallow breathing index, but not taking into account for the decision of extubate the patient, and this other, the same type of patients, taking into account rapid shallow breathing index. So no difference between the two groups, no difference at all, except in the days on mechanical ventilation, I mean in winning time in days. The winning time was shorter in this group of patients in which rapid shallow breathing was not included. So, and also there is not been demonstrated any, you know, result in any benefit in survival to using this index. So, but the point is that following these guidelines and following all this, the point is that there is extubation failure from 40 to 32%. So something happens. Clinical criteria are good for the general population, but 50% or 20% of the patients fail the extubations, fail the weaning, in spite of applying all these criteria. So let's move back to the interest of the work of breathing, because maybe the work of breathing maybe is not that, you know, that clear, but at least, as Jordi said before, it's a physiological assessment when you use assisted modes. It's the way to see how the patient is on load. And also, if you monitor the work of breathing, you can follow the patient evolution, I mean, all the resistance inside the respiratory system, how to titrate support more rational, but also, if the patient fails of the weaning, you can see what are the physiopathological, to have a physiopathological evaluation, looking at the work of breathing. So, it is very, very interesting, at least theoretically. What's the matter? So if you go to the PubMed and look, just put cardiac output. Look, papers on cardiac output, 81,000. Well, same thing with the work of breathing, right? 401. On two, I'm sorry. 402, yeah, at least. So just putting this, and if you look, maybe the work of breathing during exercise, testing work of breathing not in patients, but in healthy humans for high respiratory rate, low, everything related with the work of breathing with no limit of time, there is 402. So that's a sad story. Anyway, let's defend the work of breathing. I remember this very nice paper in where authors were defending not defending, but saying how to apply a good monitor technique. It was about the pulmonary artery catheter. And they said indication, and measurement, interpretation, application, and they have absolutely correct in all these statements. I would like to apply this for the work of breathing. And I propose that the work of breathing is still a valuable tool for respiratory monitoring. Yeah. The point is that we are going to apply all the items that are there. Yeah, correct indication. Indication, patients with complex disease process in whom the information obtained from the work of breathing may influence management. What type of patients are these? We don't know exactly. Well, the first problem. Second problem, correct measurement. Zeroing, there is not zeroing. There is always when you put the esophageal probe, there is always the weight of the heart, We have heard about this yesterday. So calibration is difficult to calibrate. Elimination of artifacts of the heart, really difficult. So this point is difficult. But the second, correct interpretation. To interpret correctly, you see that you need to know the physiology of all the elements of the work of breathing. Resistive elements, elastic elements, not only lung, but also chest wall. So it's quite complex. So this is not difficult. This is difficult plus, And the third is a correct application. Correct application means that using proven management principles and therapeutic endpoints. Do we have an endpoint for respiratory work of breathing? Not yet. So, difficult. So difficult that we don't know that. So it's very, very difficult to apply these type of principles to the respiratory work of breathing. Anyway, how we estimate the work of breathing at the bedside. There are many doctors there. You're talking about, look at this breathing better. No, I think work of breathing is high, work of breathing is low, Yeah, look at the movement of the nose. No, it's better to look at the movement of... So there is not a clinical assessment. There are some clues when you are in a clinical at the bedside. But work of breathing is a measurement. Measurements. You can say that there is signs of increased work of breathing. But you cannot say that this patient has increased work of breathing, just signs. So if you want to know the work of breathing, you have to measure. And it's not a clinical observation, of course. So we use first, you need the fourth signal. The fourth signal is the esophageal pressure signal. So we use first the novometrics from the Ventrac, from novometric in the maybe 70s, early 80s. So we have in this monitor, you see here, there is the flow meter, and this is the extra pressure, and this is in the patient. This is the flow probe, and this is this is the pressure probe. To see the esophageal pressure, and you have this type of traces. This is the flow, this is the airway pressure, this is the esophageal pressure, and this is the volume. So looking at the esophageal pressure, if you see that this is the end inspiratory esophageal pressure is 13 and the PEEP was 5, the difference is 8 centimeters of water is taken to move the chest wall. So if you have a tidal volume of 460, the compliance of the chest wall is easily obtained by this division. So it was 57, so very low compliance. And using this, you can construct the Campbell diagram. So this is the PV loop, and this is the compliance of the chest wall, and so this is the elastic work, and this is the resistive work. But with this device, you have to measure, you have to print, and you have to, to write this and to measure the surface, which is quite difficult. So we changed to the Bicor. Bicor CP100 was a special device, especially designed for measure mechanics. So you see here, flow, volume, pressure, and esophageal pressure here. So the most part of the clinical papers, the clinical studies have been used this type of monitor. So this is the catheter for the esophageal, this is the esophageal balloon. This is an nasogastric tube with the balloon here. And this is a patient, an old patient. This is the Bicor and the printer here. And you obtain, this is a spontaneous breathing patient, you know, this flow, volume, airway pressure, pressure at the mouth, and this is esophageal pressure, I mean the pressure at the pleural place, you know, pleural. This is a patient doing a big effort to move, you know, this volume, and with the Bicor, the point was he directly measured the work of breathing, constructed the graph volume pressure, esophageal pressure, this here, and volume, and constructed the loop, and measure the work of breathing here, 2.6, very high for a spontaneous breathing patient. So it was very easy to follow the patient using the Bicor. In fact, the Bicor had a special screen for weaning, looking at the strength and the endurance of the patient with several values, and looking also to the work of breathing of the patient as the result of endurance and the strength. So this is an example, and the trends graphs, like with the Bicor, work of the patient, here from mechanical ventilation to pressure support, reducing the ventilator work, and here the patient increased the patient work while changing from mechanical ventilation to pressure support. So there is a new Bicor coming next since 3 years ago, you know, improving it, but it's not yet available. What we have today is the ventilators incorporating the Bicor, the old Bicor or new Bicor, I don't know, but the Bicor, and here you can see this is the input for the pressure signal, for the esophageal pressure, the entrance of the flow. This patient here is the flow, and also here is the catheter going through the nose to the esophagus, and this is the probe, you know, and the flow, for the flow. This is, you can see here the balloon at the end of the catheter. This is another patient with a nasogastric tube with the balloon for measure, you know, esophageal pressure. And this is the trick that we do to know, to assess if the balloon at the esophageal is correctly placed. You know, just during controlled ventilation, after a expiratory pause, we promote, you know, a pressure inside the thorax, and we see the same changes in the esophageal pressure and the airway pressure, just for confirming during controlled ventilation that the catheter is correctly positioned. So you can have with this in the ventilator the esophageal pressure versus volume loops, which is this one. You can calculate here, and is measured by the ventilator too, the compliance of the chest wall, in this case 505 centimeters of water is 100, and also the compliance of the respiratory system in the airway volume loop, you know, that is quite normal. So this is what you see in the ventilator is again the airway pressure, flow, and esophageal pressure here. You know, the drops, and you can have the loop of esophageal pressure versus volume during spontaneous breathing. So with this loop, respiratory work of breathing of the patient can be measured by the ventilator. And you can also print this type of loops. This is the esophageal versus, volume versus esophageal pressure. And you see here, you know, and you can construct now, this is the chest wall line. This is the zero flow and the compliance line of the lung. So this is the starting point. So you can construct here the Campbell diagram, looking at the measurement of the elastic work of the chest wall, the elastic work of the lung, and the resistive work of the patient. So there are the three interesting parts. So we take, since 2 months ago, we take some data from patients in 10 postoperative patients in cardiac surgery, monitor with hemodynamic monitoring with the PEEP, looking at also the extravascular lung water. All them had criteria for weaning, and all them were extubated after the study. We measured two situations in assist control and after with a CPAP of 0, you know, no support at all, like TPs, but connected to the ventilator to obtain the lobe. So we measure the work of breathing with the ventilator, and we measure with the Campbell diagram all the components of the respiratory work of breathing. So that first was to realize that that measurements that we did and the work of breathing estimated by the ventilator was quite okay. You know, you can follow, I mean, the patient looking at the measurements done by the ventilator. But looking at the results of the 10 patients, as very few, but just to make an example, look at this, the total work of breathing during assist control was very quite correlated with the work of breathing during spontaneous breathing without pressure support. You know, always work of breathing during a spontaneous breathing, work of breathing is higher than measured during assist control. And if you look at the two components of the work, that's a resistive and elastic, you can realize that the resistive work of breathing is quite high in relation to the elastic work of breathing. You think that always the work of breathing is because of the compliance of the lung and the chest wall, but not when you are on the patient ready for weaning. You know, as we have heard, you know, recently, the resistive work of breathing is quite high, you know, even higher than the elastic work of breathing. And another thing is that the elastic work of breathing of the chest wall, I mean, the elastic WOB is very low, except it was low except in these 3 patients in which the abdominal pressure was higher than 18. So elastic chest wall, not in obese patient and not intra-abdominal hypertension patients, is very low. So the work of breathing for move the chest wall is quite low. Important is the elastic work of breathing of the lung. So we just correlated, yes, for give some another insights, the chest wall compliance was very well correlated with the elastic work of breathing of the chest wall. But second, if you try to correlate the compliance of the chest wall with total elastic work of breathing, correlation was not that good. But what we found was a really interesting thing just to estimate the work of breathing is that, look at this, that the lung compliance was quite very well correlated with elastic work of breathing of the lung. You know what is quite normal, elastance, I mean compliance of the lung and work of breathing due to the elastic breathing. Okay, I'm finishing. So the extravascular lung water in the patient was very well correlated to the compliance of the lung. And also, the elastic work of breathing was very well correlated with intravascular lung water. I mean, meaning that maybe the water inside the lung is important as an important part of the compliance and the work of breathing. Finally, the extravascular lung water was bad correlated with total compliance, but if you remove the 3 patients with intra-abdominal hypertension, the correlation between the elastic WOB and the extravascular lung water was very good. But all these patients with high extravascular lung water have high work of breathing and were extubated with lower PA ratio, and they needed non-invasive ventilation. So to conclude, work of breathing measurements are very complex. We agree, are very complex, are for physiological study. Accurate measurements need a special device, and always the esophageal probe. Estimation from ventilator may be useful. So you have the ventilators, please use it because it's really interesting. The resistive work is a very important component when you are to wean a patient. The elastic work can be estimated if you have estimation from extravascular lung water, and for weaning and for general weaning, please use a standard clinical criteria, but have a look on physiological components like work of breathing, I mean elastic work of breathing through extravascular lung water, of resistance through the diameter of the bands of the patient. Thank you very much.